Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hi, this is Stephen Fine in Rochester, New York, and I am presenting in this podcast on behalf of Clinical Education Initiative, the CEI for New York State. This week was World AIDS Day, recognized around the world, and because of that, there was lots of news related to HIV and AIDS. The news was overwhelmingly popular. For example, a research group in Canada reported progress in eliminating HIV reservoirs, hoping to take another step toward a durable HIV cure. Continues to be progress towards making lenacapavir available worldwide for preventing HIV, which was a subject of my previous podcast, and that work has continued to progress. Not everything was positive, of course. There were still lots of disturbing reports about mental health and stigma related to HIV that continue to persist, and that many people eligible for PrEP, pre-exposure prophylaxis, are still not taking it. Although new infections are declining in many areas, there are still far too many infections from HIV, and in some places, the number of new infections is actually going up. Tuberculosis remains the leading cause of death in people with HIV worldwide, and a number of news reports highlighted that in the U.S. and worldwide, the number of HIV clinicians continues to shrink at an alarming rate. This news continues to highlight the overwhelming importance of preventing new HIV infections. Use of pre-exposure prophylaxis for people at risk of HIV is more important than ever. While the world awaits institution of twice-yearly pre-exposure prophylaxis injections, we continue to increase the access of injectable PrEP that we have currently, which is Cabotegravir, as best we can. One question I hear quite often in talking about Cabotegravir injection for pre-exposure prophylaxis is whether or not it's safe to use during pregnancy. This continues to be an extremely important question because many times women who are at risk of acquiring HIV are also of childbearing potential, and both the women and their clinicians may be hesitant to try Cabotegravir for pre-exposure prophylaxis if they might become pregnant. In this podcast, I'm going to review a study that was presented at the 25th International AIDS Conference, IAS, this summer, 2024, which was designed to answer the question definitively. So hopefully this will decrease hesitancy amongst both women and their clinicians in the population that really needs HIV prophylaxis desperately. The study I'm going to present is from the HIV Prevention Trials Network, affectionately known as HPTN, and the study is 084. Overall, I believe the results are going to show that Cabotegravir LA, used for pre-exposure prophylaxis, both before and during pregnancy, was both safe and well tolerated by pregnant women and the babies. HPTN 084 was a large trial versus tenofovir FTC in cisgender women in sub-Saharan Africa. Results presented in 2020 initially showed that injectable cabotegravir was superior to TDF-FTC in prevention of HIV, most likely due to adherence barriers for oral PrEP. The study enrolled 3,200 cisgender women who were at high risk for HIV in sub-Saharan Africa. After those results were published, participants were allowed to go on open-label long-acting cabotegravir for PrEP. This arm continued over the next 3 years, and importantly, contraceptives were not required in order to continue taking long-acting PrEP as part of the study. A sub-study of 50 participants looked at the pharmacokinetics of Cabotegravir LA, both before and during pregnancy, and in all, 367 pregnancies were reported and evaluated as part of the study. Pregnancies during the study were confirmed by urine samples, and the pregnancies were then categorized by whether the women had been exposed to Cabotegravir LA during the pregnancy, or just before pregnancy, or never received Cabotegravir LA injections, but instead had continued on the tenofovir FTC arm. Of the 3,200 initial participants in HPTN 084, 2,472 decided to continue with the open-label arm. At the International AIDS Conference, data was available for about 367 pregnancies total. 212 pregnancies were recorded in women actively taking Cabotegravir LA during pregnancy. 68 had received Cabotegravir LA before pregnancy, and 45 of the pregnancies had no Cabotegravir LA and were instead taking tenofovir FTC. Overall, there was no difference among these groups for the age at which pregnancy started, prior pregnancy history, or history of sexually transmitted infections. Pregnancy outcomes were compared between the groups and to historical norms in the region. There were no differences between the three groups in the number of women requiring C-sections or experiencing delivery complications. There were no deaths in any of the groups, and no HIV infections were discovered during pregnancy in any of the participants. Some examples of the data from the trial showed that full-term births at 37 weeks was 67% in both the Cabotegravir active arm and the no Cabotegravir arm. Preterm births were 5% and 7% respectively, and it was noted that the background rate of preterm birth in the region is 6 to 22%. So this is well within that parameter. They noticed a spontaneous abortion rate at less than 20 weeks within the Cabotegravir group at 20%, within the background rate of 15 to 30%, but also highly cautioned that this data is very difficult to interpret because of the variable legal status of abortion in some of the HPTN countries. They then looked at the incidence of infant growth parameters such as head circumference, infant length, and weight at birth, and noticed no substantial difference between any of the arms. There were unfortunately some neonatal deaths in the trial, all of which were investigated carefully. None were considered related to the pre-exposure prophylaxis by investigators, and the overall prevalence rate of 2.5% of neonatal deaths was actually consistent with the background rate in those countries. Overall, this is the largest amount of clinical trial data to date on outcomes of pregnancies in women taking long-acting Cabotegravir for pre-exposure prophylaxis for HIV, both before and during pregnancy, and hopefully will be reassuring to both women contemplating pre-exposure prophylaxis who may become pregnant, as well as their providers. I mentioned previously that there was a sub-study in 50 participants looking at the drug levels and pharmacokinetics of Cabotegravir injectable during pregnancy, so I can avoid going into the dry details of pharmacokinetic studies. Suffice it to say that the pharmacokinetics showed that the levels of Cabotegravir in the blood of women does decline during each trimester of pregnancy. However, throughout the pregnancies, it did remain well above the levels that were considered effective for pre-exposure prophylaxis. Therefore, the conclusion of the pharmacokinetic part of the study is that no dose adjustment would be required. Long-acting injectable Cabotegravir is going to play an important role in HIV prevention for the foreseeable future, at least until injectable lenacapavir every 6 months is made widely available. Hopefully, guidelines updates and insurers will realize the importance of injectable Cabotegravir for prevention of HIV and decrease the barriers in women who might become pregnant, and decrease the barriers for those patients, enabling them to access the medication at a time when they need it the most. This is Stephen Fine in Rochester, New York, presenting this podcast on behalf of Clinical Education Initiative, the CEI, and for New York State.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.